This year, I'm going to be doing a series of lectures on medical and healthcare issues after disasters and major accidents. And in the first one, I'm going to talk about reducing harms after radiological, nuclear, and chemical emergencies. Now, these are broadly defined as radiological incidents where you don't have a blast or explosion from a nuclear event, a nuclear incident where there is a blast or exposure due to nuclear fission, and then chemical, which can be deliberate, so chemical warfare, for example, poisonings, or accidental. Now, in the chemicals, I'm really going to talk just as about the agents that are used in military uses. Throughout this, the key thing to understand with both radiological and with chemical issues is an old saying from Paracelsus in the 16th century that the dose makes the poison. Very low doses of either radiation or of even quite dangerous chemicals are usually harmless, or you recover from them really quite quickly. High doses, of course, are what cause significant problems. Radiological, nuclear, and chemical incidents tend to cause widespread and very understandable concern. They tend to dominate the news agenda, and they are indeed dramatic and are turned quite frequently into dramas, including two very well-regarded ones I've put up here. This talk, however, is going to think much more about the science of these events, and also what we can do in health terms to minimize the risk to individuals, to families, after the event. Radiological incidents from mainly from civil nuclear installations are the most common of these, although even these are very rare. Some important large-scale events include the Fukushima and the Chernobyl disasters, which I'll talk about in more detail. But there have also been leaks from nuclear installations in the USA, 3 Mile Island, for example, and in the UK in Windscale, mainly very small and with limited health impacts. And there have been several smaller incidents along the way. Now, it's important when thinking about this to recognize that power generation, at least by conventional sources, has always had a risk to health. And most conventional power generation causes substantial air pollution. And this causes very significant harm. Coal burning for production of power, in particular, is extremely damaging to human health, and through air pollution can cause increases in heart disease, stroke, lung cancer, and many other potential diseases. And nuclear power needs to be seen in that context. I have given a talk previously at Gresham College on the risks of air pollution. And here's a graphical way of really demonstrating this and showing that deaths from air pollution and other accidents are much higher, actually, in terms of numbers, particularly from the most polluting form of coal, called lignite. But coal in general has, and to a lesser extent oil burning, have very significant potential health impacts due to air pollution. Moving on to radiological incidents, accidents tend to be either due to the human error or to natural disasters, and there can be some combination of those. Chernobyl in 1986 is the best known, the best studied, and the largest of these. The causes for it were complex, and a whole series of things essentially lined up. A combination of poor design of the reactor and human error led a test shutdown to lead to an energy surge. And then there was an explosion caused by steam, and then a secondary explosion which breached the core. And then there was a reactor fire, and that led to radioactive material being carried a long way up because of the heat of the fire into the atmosphere, and then it tracked around over Europe for quite some time. I'm not going to go into the details of this. Those who are interested can look at the IAEA report on this, which is really the definitive version. Fukushima in 2011 in Japan was largely caused by a natural disaster. An earthquake led to the reactor shutting down, as it was designed to do, but then there was a subsequent tsunami wave which damaged the cooling system, and then the reactors overheated and there was a partial meltdown. And then there were subsequent explosions, mainly due to hydrogen buildup. To be clear, this is hydrogen, the gas. This isn't a hydrogen like a hydrogen bomb. This is actually just buildup of hydrogen gas, which exploded and breached the core. Again, there is an official report of this for those who are interested in the details. Now, after there's been an accident, there are broadly 4 kinds of effects on health. The first of these, the first 2 of these, are really only going to occur for people who are in the immediate vicinity, generally people who are actually nuclear workers or emergency workers on the site at the time of the emergency. There's physical trauma, if there are explosions, and there were explosions in both those 2 cases, and then there is acute radiation sickness, which I'll go on to describe in the next few slides. For those not actually on the site, there is a risk, but it's massively lower, and the longer-term effects, which can occur for people who are exposed usually to a radioactive plume downwind, are cancers, but the rates of those, as I'll show, are low, in fact, and then psychological effects. And the studies of Chernobyl nuclear disaster survivors showed that these psychological effects were often both the most common and in many ways the most severe. So people worry about it after the event for understandable reasons. To understand the risks and how to reduce them significantly after an event, it's important that we have a basic understanding of radiation. So the next few slides are really going to just run through some key bits of understanding of radiation. There are broadly 3 types of radioactive material or radioactive exposure which are important after a radiological and indeed a nuclear incident. Alpha particles, these can travel just a few centimeters in air and they can be stopped by a variety of relatively small barriers. Then there are beta particles, more important, and these can travel tens of centimeters in the air, but not huge distances, and again, they can be stopped by slightly larger barriers. And then finally, there are gamma rays. These are not particles, these are waveforms, and they can travel many meters to some kilometers, but not indefinitely. But the further they travel, the more their energy will be attenuated, reduced. So the effects will weaken over distance. And just, to reiterate this point, alpha particles are stopped by things as limited as paper and the outer, therefore dead layer of the skin. So really, it's only if significant amounts are ingested, they tend to cause any significant harm. Beta particles, again, more important, are stopped by glass, aluminium, and other relatively small barriers, or at least very significantly reduced. And gamma rays can penetrate those, but they are significantly attenuated by walls and made of brick, concrete, or stone. And essentially, the larger the mass between you and the gamma ray source, the lower the dose of radiation that you're going to get. Repeating my constant refrain through this talk, the dose equals the poison. If you can reduce the dose, then the effects will be much smaller. The human body is remarkable in its ability to handle and to recover from large numbers of assaults on it, and radiation is one of these. Radiation is actually occurring in the background every day. There's radiation in almost all environments. Some buildings have higher levels of radiation. Quite a lot of very healthy foods have traces of radiation. Tobacco has radiation. And so you're being exposed to radiation the whole time. I'll come on in a second to kind of the doses we're talking about. At a higher dose, in medicine, we use radiation in broadly two ways. It's used diagnostically using X-rays, and people who have an X-ray, have a CT scan, are exposed to very small amounts of radiation, which really have, for practical purposes, with the exception of fetuses for women who are pregnant, but for practical purposes have no increase in risk under ordinary circumstances if people just have a single X-ray. And then at a much, much higher dose, radiotherapy, which is based on the fact that healthy cells exposed to radiation may be damaged, but they will then recover from the radiation dose. So the body can both handle small amounts and recover from larger amounts. Now, I talked about cancer treatment in a previous series at Gresham College. I'm not going to go through this in detail, but I think it's just useful to understand this background for understanding the wider risk. So the way in which radiotherapy occurs, a variety of ways of achieving it, but the most common thing is to fire external radiation at the body from multiple angles so that there's only the area with a cancer in it has a very, very high level of radiation. The other areas of the body that the radiation passes through has a much lower level, and those cells will recover. So again, this is just a demonstration of the fact that normal cells will recover from radiation in the great majority of cases. And a variety of ways of doing it. On the right, I've shown how both X-ray type and proton beam therapies can be used for this concentration of X-rays where a cancer is found. The way in which you measure the amount of radiation can get quite confusing. Gray's, Sievert's, a variety of ways of thinking about it. One way that people have thought about it is the number of bananas you'd need to eat to achieve the same amount of radiation exposure. Because even bananas, very healthy food, like many other foods, have a very small amount of radiation in them. And on the left here, you can see essentially the banana equivalent. This is a slightly crude scale, but it's just to give a sort of sense of relative scale of the amount of radiation you get. So your normal background dose would be around about 100. A dental X-ray would be lower than that, so it's less than a day's worth. An X-ray of the chest might be somewhere between twice and 5 times that, so 5 days worth of background radiation. By the time you get up to CT, slightly higher than that, but really a very substantially greater amount of radiation for radiotherapy, and a massively higher dose if you're to have a fatal dose. These are the kinds of levels of radiation which actually are going to cause really substantial harm. So low doses we handle as bodies really well. So the first of the major causes of illness after exposure to radiation is acute radiation sickness. This is by far the most severe end of the spectrum, and a relatively or very small number of people will be affected. But for them, this is a serious risk to their health for this. And these, as I say, will be people really just on the site of an emergency generally. There are 4 subsyndromes, a variety of ways of describing this, but they're all caused by the fact that radiation has its biggest impact on the cells in the body that are rapidly dividing. And the 4 are the hemopoietic system. This is the thing that makes blood. It makes red cells, makes platelets, which stop bleeding, and importantly, it makes white cells, which fight infection. And if the bone marrow is temporarily, essentially switched off because of the damage from the radiation as it recovers, you can have a period of time when people have anemia, but more importantly, they are very susceptible to infection until their white cells recover. Then there's the gastrointestinal system. The gut rapidly turns over with diarrhea and a variety of other gut problems. The cutaneous system, the skin system, including hair, and then the neurovascular system, which really only tends to be affected by very high doses indeed. All of these are, in the great majority of people, temporary. So they will recover, but for a period, they will be at significant risk because of radiation sickness. And for those who get radiation sickness, there are 4 stages, and not everybody goes through all of them. The first of them, which happens commonly, including people who actually go on to have no further issues, is a prodrome. People feel really very rapidly, they have vomiting or a nausea, headaches, loss of appetite, diarrhea, fever. And this is a short-term effect, and it then improves. Then there's a period for days to weeks, and the bigger the dose, the shorter the period, where people make an apparent recovery. In more severe cases, they may have some hair loss, but otherwise they appear to get better. And then weeks to months later, there is a period of illness, manifest illness, where people have diarrhea, infection, anemia, and during this period they are very vulnerable, particularly, as I say, to infections. And then, except in people who have the heaviest dose, there will be recovery, and people will recover largely or completely from their radiation dose. To give some sense of scale, remembering that Chernobyl was the largest civil radiological event, that had probably about 134 acute radiation sickness in total and around 28 deaths. Fukushima had no deaths from acute radiation sickness recorded at all. So these are rare, but these are obviously serious when they occur. And what will happen depends on the dose. So at a relatively low dose, this is measured in grays on this particular thing. These data are, again, open source. People will have the prodrome. They may have the nausea, vomiting, and anemia. And they may subsequently have a slightly increased risk of infection and of fever, but the recovery will be relatively quick. There isn't severe disease, and there will be no mortality in people who've had this kind of very low dose overall. At a high dose, but not a completely lethal dose for most people, here's someone who's been exposed to 3 to 5 grays, which is a much higher dose. They'll have a much wider range of symptoms, much longer and more severe fever, infection, diarrhea, weakness, and the mortality rate at this kind of dose would be somewhere between 5 and 50%. So still the majority of people will recover, but they will be very sick for a period of time and need very careful medical care. And then at very, very high doses, the effect will be lethal, but that's exceptionally high. So that's acute radiation sickness, very small numbers, very heavy exposure to radiation. The other thing that people understandably worry about is cancer. And this has been studied both in Chernobyl and in Fukushima. And I think it's worth looking at some of the data, and I've chosen Fukushima to do this. There was a really heavy study by the World Health Organization, WHO, looking at this. The first thing I want you to look at is the map on Fukushima, which is on the right of this slide. And in red, that red streak is where people had a high dose, potentially, exposure from the plume of radioactive material that moved downwind away from the reactor after it had been breached. In blue, a much lower exposure, and other areas outside that, really no exposure for practical purposes at all. And I wanted to show really 2 things with the graph on the left of this slide. The first is that the risk of a subsequent cancer is very much dependent on the dose. So in the risk of people in absolutely the middle of the red area, the highest exposure in the plume nearest to the reactor, have, unsurprisingly, a higher risk of cancers than those, than they're the ones on location 1, than those in location 8, which is much further away from the plume, but still affected. The second thing to note is that this varies by age. So if children under 1 are exposed, they have a higher risk, not a massively higher risk, but a slightly higher risk than those who are older children and higher, again, than young adults. So age does have some implication here. But, and I think this is where it's important not to get things, see things in the wrong perspective, if you compare the risks as a result of this exposure to someone's lifetime risks overall, the actual proportionate increase caused by having been exposed to this radiological accident from a nuclear power station are actually extremely small. And the dark blue or the blue bars at the top of these are the actual risk, and then the grey bar below it is the lifetime risk not caused by the radiological events, but by everything else that someone goes through in life. And as you can see, really, even in this this relatively heavy exposure compared to others, the actual increase in risk over a lifetime is small, still larger in someone who's a child than someone who's an adult, but still in both of those small. And what we have shown on this is solid cancers on the left and leukemia, bone marrow cancer on the right. There is, however, one particular cancer which is made more likely by exposure and where the effects are attributable. It's a very rare cancer. It's made more common by radiological exposure, but it's still very rare in absolute terms, and that is thyroid cancer. And again, worth looking at really two things. Firstly, on the right, this is really to demonstrate, again, this effect that small children are at a higher risk than adults. And secondly, that women are at higher risk of thyroid cancer than men, and that is also true after radiological exposure. And you can see this in terms of the lifetime attributable risk, again, on the bit of the graph on the left. What you can see in the grey bars is what people would have had they not had the exposure. The blue bars are the additional risk as a result of exposure. And this is in area 1. This is the people who are most exposed immediately downwind of the reactor. But the numbers involved are very small, and it's important to stress that thyroid cancer, the great majority of people will not get thyroid cancer, and of those who do, the great majority will in fact survive. So looking at the Chernobyl risk, after 30 years, so this is after a long follow-up, the total number of people who had thyroid cancer at all, this is all causes, this isn't just caused by radiation, in the 3 most affected countries was about 11,000. But only a fraction of those will have been due to radioactive iodine, and most would make a full recovery, even of those who've got cancer. Very modest increases in other cancers for those who were exposed to long-term radiation. And there was probably a small, but not substantial, but small, but real risk of increase of cardiovascular risk and also of cataracts of the eyes. All of these are dose-related. So if you can reduce the dose, you substantially reduce the risk that any of these will occur. But to make a point I made earlier, by far the most common implications were mental health issues, where people were very worried that they or their families would be suffering as a result of having exposed to radiation. And it was actually this concern that was probably the bigger risk than the actual risk of cancers and other physical harms. So since the body can deal with very small amounts of radiation and recover well from low to moderate ones, the key thing is to reduce the dose of radiation. And after an event, there are 3 ways to minimize exposure. Reduce time, so the amount of time you're subject to radiation, increase distance from you and the source, and shielding, putting a barrier between you and the radiation source. So if you assume a fixed concentration, the risk is broadly proportional to the time exposed. So the less time you have exposed, the better, and nuclear workers are trained very heavily in this. Distance is very important. So at a distance of a few kilometers from a radiation source, there will be no alpha or beta radiation, and gamma will be minimal. So keeping away from sources, either the actual accident or a plume, if you can put distance between you and them, the impact will be extremely small. The plume of radioactive material, if there is one, as it moves, is likely to get larger physically, but also to dilute. So a larger number of people may be exposed to a much lower amount of radiation. But it is important to track the plume and to make sure people who are likely to be under it are aware of what to do to minimize their risk. And finally, shielding is a very effective way of preventing alpha and beta radiation, putting a barrier between yourself and the radiation source, and significantly effective, but not completely effective, against gamma radiation. I'll go on to that in slightly more detail. But to summarize, to reduce your radiation exposure, limiting time, increasing distance, and using shielding will significantly reduce the dose, and the dose is what predicts how bad the possible outcomes will be, both short-term and long-term. If there is a nuclear event, and this is just an example of plume modelling, there will be expert groups will be providing maps of and predictions of where this is going to go based on weather conditions. And this will depend on several factors: how far up it goes into the atmosphere. So much higher temperatures will any kind of explosion may loft things much higher than if that doesn't happen, and the wind will go in different directions depending on which height it is. The wind speed and direction is obviously important. Things like precipitation, rain and other events will have big implications for how quickly it's washed out. And also local factors on the ground will have big implications for exactly how much concentration occurs. So the Met Office and others will model any kind of plume and be able to predict in which direction it's likely to go next. So apart from the people immediately on the site, the plume is the major risk, and this is what will affect anybody who is affected who isn't immediately on the site. And I think that the key thing here is to understand the device and the reasons for it after an event. And the first bit of advice is get inside, and then stay inside, don't venture out, and finally stay tuned to try and get advice as to when it is going to be safe for you and your family to move. The reason for this advice is really flows from what I said earlier on about the way in which radiation works. Houses, offices and schools, built usually of brick or concrete or stone, provide very good short-term protection. We're talking 1 to 3 days against alpha and beta radiation. They may land on the walls, they may land on the roof, but they will not be able. The radiation will not penetrate them, and from other elements of radioactive dust. But it is important that you then close windows, block off any holes, turn off the air conditioning so that air is not coming in from the outside. They will also substantially reduce gamma radiation, but you want to get as many walls between you and the outside as possible, because the greater the mass between you and the radiation, the smaller the dose you are going to actually receive due to attenuation. Cars, on the other hand, are much less safe. And this is one of the reasons that the advice is not to immediately jump in your car, pick up the family and drive. Firstly, other people may well have had the same idea, so you may be stuck on the roads. And secondly, you will have much less protection in a car than if you are in a building. But if there is time to evacuate, do so, but with advice. And the reason for that is plumes may not be where you think they are. You can't see them. It's the mapping of them that will tell you where the risk is, where it's going to be in the next few hours and days. So just to give some idea of this, any house will provide protection, but again, the more walls there are between you and the outside, the better. And this is just a kind of graphic to give you some idea about where you want to go. You want to go essentially into the center of the building, down into a cellar if there is one, because that puts more distance between you and the roof. A typical brick house will reduce this down by about 0.015, so essentially 85% reduction. And a multi-story building will reduce it even further because there's more concrete and brick involved. The next thing you can do and should do is decontamination if you've been outside during a radiological or indeed nuclear emergency. And for radiation, I'll come on to chemicals, which are slightly different, but for radiation, important to understand that minutes don't matter here. The key thing is that you do this effectively. So if you've been outside, remove your outer clothes. And ideally, if you're in the right kind of environment where you can do this, remove all your clothes, put on clothes that are clean and haven't been contaminated. This substantially reduces the risk. So any kind of beta emitters or alpha emitters on those clothes are then off you. They're not going to penetrate. They're going to be some distance away from you. Double bag them, put them some way away from where you are. Then shower using soap, lots of water, but don't put in conditioner because that can lead to things sticking to your hair. So just soap and water, mild soap and water, will just get rid of further amounts. And this will generally remove more than 90% of the radiation on you. So this is an effective way, again, of reducing the dose, remembering the dose makes the poison. Then it's worth thinking about what other things you can do, particularly from the risks of radioactive material that's been ingested. And the Chernobyl accident really provides the model for which isotopes are important. So quite a lot of radioactive isotopes occurred actually on the site of the reactor, but only really two became important in medical terms outside. Radioactive iodine and radioactive cesium. And they provided more than 90% of the radioactive material in the plume, so they were really the big risks. And they have slightly different properties. Radioactive iodine has a relatively short half-life, just over a week. So that means that the dose is going to be dropping very rapidly over the first 2 or 3 weeks, and will decay away in months to a point where, for practical purposes, it's not adding much risk. Cesium, on the other hand, has a much longer half-life, so this will survive in the environment for a much longer period of time. But they do actually have different medical properties. Iodine, generally iodine 131, is a product of uranium and plutonium, both of which may be used, or either or both of which may be in the reactor. It's also used in medical treatment. Most of its radiation is beta, so it's quite short range, and therefore the risk is if you ingest it in some way. There's a much smaller amount of gamma radiation. The reason it's important, however, is that it's taken up by and concentrated by the thyroid gland. And that is because the main thyroid hormone is based on iodine. So the thyroid gland seizes iodine that's passing and concentrates it in the gland to make thyroid hormones. And the problem with this, therefore, is you get a very heavy concentration of the iodine, which might, at the very low levels in the rest of the body, really has minimal effects. And because it's highly concentrated in this area, it is therefore, and producing beta emissions, it therefore can cause local damage to the thyroid gland. And this can do two things. It can damage the thyroid gland so it doesn't continue to produce its hormone. Now, that is a nuisance, but it is an entirely manageable process. Lots of people have to have thyroid replacement therapy. It really then means people have to have thyroid replacement therapy subsequently with just oral drugs. But there is this increased risk, which I talked about earlier, of thyroid cancer. Important to note that radioactive iodine of different forms is used also for treatment, sometimes for an overactive thyroid, and sometimes, in fact, for treatment of cancers themselves. So it is given, but obviously that's in an environment where you're trying to treat a disease. So this issue about radioactive iodine in the thyroid means that it is worth, if you know you're about to be exposed, taking iodine to reduce the risk of thyroid cancer. And the reason this works is by flooding the body with iodine just before the event, the thyroid is then taken up a huge amount of iodine and is much less likely to grab radioactive iodine as it goes past, reduces the risk of it being concentrated in the thyroid subsequently. So for people exposed to significant risk from inhaling iodine from the plume, the recommendation is to have stable iodine given between 24 hours before and 2 hours after. If you give it later than that, it actually can do more harm than good. So you definitely want to do it before the event. And then longer-term risks can occur from milk products and food, but these can be picked up by people detecting the radiation and essentially taking them out of production. So that side of things will be dealt with by safety measures on food subsequently. So it's really that initial risk under the radioactive plume. Those who are not under the plume are not at risk from radioactive iodine. Cesium, 137, is, as I say, longer lasting. It's also water soluble and potentially stable, so it can spread through the environment. It is taken up by humans, but it's very rapidly excreted in the same way that potassium is excreted. So it's actually quite rare that people will get significant amounts of cesium concentrating in the body, remembering that the body is extremely good at dealing with low levels of radiation and recovering from moderate levels. So the biggest problem from cesium really is the fact that it has a relatively long half-life. And you can see on this map where cesium was deposited in Europe, and this has implications for subsequent agriculture in those areas, potentially, where red is high amounts. It's very unlikely that tap water will be contaminated to a significant degree, so that's not a worry that people should have. They can still drink tap water unless told otherwise. And anything that's indoors, in your house, indeed in a supermarket, before the accident is safe to consume. It won't have been contaminated. The only real risk is vegetables outside when contamination occurred, so if you've got a kind of plot outside, then don't start digging up your lettuce or whatever it is straight afterwards. Seems an obvious point. And remembering that over 90% of radiation from food is naturally occurring and at very, very low levels, what will happen then is there will be a safety assessment of all the different foodstuffs, and where there's a risk, it'll be removed from the food chain. So the risk really, from this point of view, is likely to be very small. So that's what to do after a radiological event, and this is the majority of the talk. But I wanted now just to talk about some events which we hope will never happen again, but it is worth understanding a bit about the medicine around these. And the first of these is a nuclear device explosion, a nuclear bomb. This will cause death and destruction and disability via 3 routes. The first is blast, straight blast. It is an explosion, it's a very large explosion, and people will be killed by that explosion. The second is thermal, flash, where people get burns. And the third is radiation. Radiation, of course, is the one that's specific to nuclear devices. The great majority of the death will, in fact, be from blast and the firestorm that goes with it. So those two are what will kill the great majority of people, and did so in the Second World War. Depending on the nuclear device, size and variety of other things, there may be a zone where people survive the blast but have a lethal, severe, or moderate amount of radiation sickness. For many nuclear devices, that won't actually happen. The blast will essentially kill everyone who's going to be killed anyway, unfortunately. But some devices, there may be a sort of outer layer where radiation sickness is important. And then the radioactive plume principles are exactly the same as for a civil radiological event. You get indoors and you stay indoors until you're given advice to move because it's become safer to do so. One slight difference is that radioactive iodine is much less important in plumes which are created this way, and therefore getting stable iodine is of practically much less importance. Now, the physics of this I'm not going to go through, but just to say that the size of the nuclear device will determine whether there is a zone of people who get acute radiation sickness but who were not killed in the initial blast and fire. In general, what this graph is demonstrating is that the dark blue line is the radiation injuries at a high enough level to cause very significant harm. And as you can see in small nuclear devices, there may be a group of quite a significant group of people who have radiation injury beyond the blast radius. For very large very large nuclear devices, essentially everybody would have been killed in the blast and fire, unfortunately. But let us hope that this never occurs again in the future. Within this, there's a lot of variation. Buildings, terrain, hills, variety of all these kind of environments will have implications for both the effects of the blast injury and burns and radiation in due course. And how high up the device is when it explodes will also have implications. But I think probably the details of this are unnecessary at this point. The point is, unfortunately, with a large event, most people will die in the blast. So now to move on to chemicals. And I'm really just going to talk here about chemical warfare agents, but some of the points that I'm making in general are applied to all contamination with dangerous chemicals. At high enough doses, many chemicals and drugs, given quite perfectly appropriately by doctors, can be toxic. And some are indeed occasionally used as poisons, where people deliberately give someone a much higher dose than is safe. But in general, if you keep within the recommended dose, they will do much more good than harm. A much smaller number of chemicals have been designed deliberately to kill and maim humans. And there are three classes in particular. There are some others, but three in particular have been used, unfortunately, over our recent history. The first group are the blistering agents, of which mustard gas is the best known. The second are the choking agents, of which chlorine and phosgene are best known, and all of these, unfortunately, were used in the First World War. I'll go through them in a bit more detail. And then the third group are the nerve agents, especially the organophosphates. Start with the blistering agents. There are several of them, but the three probably best known, sulfur mustard, also mustard gas, lewisite and nitrogen mustard, are the ones that were used. And you can see on the right of this some of the studies of these agents on people at different concentrations on the effects on people's skin. Sulfur mustard is a gas or an oily liquid. So it's not just a gas, you actually can have it in liquid form, and therefore people touch it and get blistering from that. And it causes its damage by skin contact, eye contact, and inhalation. And all of these, it causes severe burns and blisters, eye damage and lung damage. It's often not immediate. It can be delayed by up to 24 hours. It's heavier than air, and this is important if you're having to get out of an environment where this is there, so it sinks to low-lying areas. It's one of the reasons it was used as a military agent, because it sunk down into trenches and foxholes and so on. And in normal weather conditions, it lasts about 1 to 2 days. It can be slightly longer in cold weather. The key if someone is exposed to this is get them out into fresh air and remove all their clothes immediately. So unlike radiation, where speed is much less important, speed really is absolutely essential. You've just got to do it immediately and then go on to do decontamination, which I'll come on to. There are no antidotes to these agents, but the great majority of people will survive them, but it's exceptionally painful for the period over the next few weeks, and it may cause some scarring. So extremely unpleasant agents. Subsequently, mustard gas agents, however, were then used because of their damage to cells. They were then studied for their effects in medicines, and from them several drugs were in fact developed, some of which are still in use. Because they cause damage to rapidly dividing cells, that's really where they cause the most damage. This can lead, it was seen that this led to a drop in white cells, and as a result of that, doctors initially in the States started trying to see if this could be used, these drugs could be used to treat cancers of the blood cells, and the first patient who had this was someone with lymphoma. And the drug significantly improved their lymphoma with repeated doses, but eventually they relapsed. But this was really the start of chemotherapy. So chemotherapy actually derives in part from these appalling military agents. Then various pharmacologists used those principles and found mechanisms to make them much less toxic to the general individuals, and this led to a series of drugs which are still used today in chemotherapy. Probably the most widely used is a drug called chlorambucil, which is essentially derived from this by several removes, still used as a chemotherapy agent, and also used for severe immune diseases. So this has gone into medicine from military agent over many years. The second groups of agents are the choking or pulmonary agents that affect the lungs, of which the best known are chlorine gas and phosgene. Very extensively used in World War I, but they're also dual use. They're used a lot in chemical processes. So these are drugs which were known in industry for other reasons. At very high doses, again, a very low dose is entirely manageable. At very high doses, they cause burning sensations of the lungs, eyes, coughing. In very high doses, you get fluid on the lungs, pulmonary edema. And phosgene can additionally cause heart problems. Like with the mustard group, the blistering group, the key thing is get away and get clothes off as fast as possible. Most people will make a full recovery in between 7 and 14 days, but extremely unpleasant in the intervening period. Phosgene has a higher mortality rate, but still the majority recovered. But phosgene, in fact, was the chemical agent which killed the most people in World War I. The third big group, not used in this way in World War I, but subsequently developed, are the organophosphates and the carbamates. These are the nerve agents. That's how they're popularly referred. These were originally developed as insecticides and pesticides. And we still use them, this class of drugs, in very different doses and different formulations for that purpose. Sheep dips, for example, would have organophosphates to help kill ticks. If you treat yourself or children with malathion, it's an incredibly low organophosphate used to treat head lice and scabies. It's a very effective drug, doesn't have any problems of a significant sort with toxicity, if used as intended. So it was actually developed for medical and agricultural use. The way they work is via the acetylcholine system and an enzyme that breaks down acetylcholine called acetylcholinesterase. Acetylcholine is used by lots of different species, human, but also insects, as a neurotransmitter in multiple parts of the body. It's really widely used across all of biology. In neuromuscular junctions, it causes muscles to contract. It also affects the brain, can affect it's used in the brain, sympathetic and parasympathetic nervous system. So it's got large numbers of effects. And what normally happens is the acetylcholine is released, it then binds to the receptor, it leads to the action, and then the acetylcholinesterase breaks it down in nanoseconds. So the system turns on and then immediately turns off unless more acetylcholine is released. These agents stop the breaking down of the acetylcholine, and because of that, the system is then always on. It's not in the kind of balance, it's always on, and this is what causes the damage. These agents at high doses, and the doses used to actually damage humans deliberately rather than as an insecticide or to treat conditions, can be delivered in a variety of ways. They can be delivered as gases, which the most well-known is sarin, and they can also be delivered as liquids. In military terms, this is an area denial agent, of which the best known was VX, but in the UK, unfortunately, we've also had, due to deliberate use, Novichok, which is another of these organophosphate agents. The symptoms of organophosphate poisoning are twitching, shortness of breath, diarrhea, involuntary tearing, pinpoint pupils in a moderate dose, and in higher doses, still convulsions, coma, cardiac arrest, respiratory arrest, and death. So, as with all of these things, dose makes the poison. Very, very small exposure will be dealt with by the body relatively quickly. If you've got very high doses, potentially lethal amounts. There are treatments for this, of which the most widely used is atropine, which blocks some of the receptors, so it reduces some of the effect of this, so it blocks some of the acetylcholine receptors that this acetylcholine is going to affect. But the treatment is only moderately effective, and you have to wait until the system has recovered, which can take a very long time if people do make a full recovery. For all of these chemical agents, and the same is true if you're talking about industrial chemicals that people are exposed to, decontamination is absolutely critical. And there is a real need for speed in decontamination with chemical agents in contrast to the radiological incidents where speed is less essential. You need to remove all clothes possible. Don't pull things over the head. If you've got scissors, just cut them off to avoid them being smeared over the face, the eyes, and so on. Then they should be double bagged and put a long way away from anywhere where anyone is. If it's an oily substance, then dab it off quickly initially. This is to avoid it being spread more widely, so using kitchen towels, for example, would be a good way of doing that. And then go on to wash, shower, ideally, with copious amounts of water and potentially mild soap. That basically is decontamination. And then remove contact lenses, which could have concentrated some of the chemicals inside them. So removing all clothes, removing excess oily material, and then lots and lots of water and mild soap really is the way to reduce the dose as much as possible. So that's really an overview of the major radiological, nuclear, and deliberate chemical incidents and accidents. Throughout all of this, the point I was trying to emphasize is the dose makes the poison. And therefore, since the body is so good at dealing with very low doses, if you can minimize the amount of dose, the chance of harm are substantially reduced and may well, for practical purposes, for long-term harm, be close to zero. Whereas if there's very high dose, then the risks obviously are much greater. So reducing the dose is the key. Except for those in the immediate vicinity of radiological, nuclear, or chemical incidents, it's possible very substantially to reduce the dose by taking relatively simple measures. Generally, at very low doses, the health effects are small and temporary. And even for moderate doses, the body is remarkably good at recovering from things. It's got extraordinary regenerative capacity. For radiation, get inside, stay inside, and decontaminate if you are outside in the, under the plume. And for chemicals, rapid removal of contaminated clothes, further decontamination with copious showering, and then seeking medical care are the best ways to minimize the risk this is going to cause any long-term medical harm. Thank you very much.